My name is Armin. Today what we're going to be talking a little bit about is shoulder assessments, what we do, how we treat it. Super excited to go over this with you all. Today we're going to mainly go over the flow of assessments that I normally do if somebody walks in and they're experiencing shoulder pain. As we go through those assessments, I'll talk a little bit about what we would normally find if it is a positive test, and we'll do other videos to do a detailed treatment of what we would do if we did find a positive test. So for example, if we do a rotator cuff specific test, he tests positive for it, what we would actually do to treat that. So stay tuned for those videos to come. But today, our patient here, he comes in, he's experiencing shoulder pain in the right arm. Couple of common things that often come up. Usually patients will be worried, is one shoulder lower than the other? Something to note that on average, most people will have one shoulder lower than the other, and it's predominantly their dominant side. So be aware of that. Don't always take that and say, oh my God, one of your shoulders is lower and this is a big problem, or so on and so forth. So really make sure you do the full assessment to get an idea of what's going on and put it all together. So the first thing that you want to actually do is a bit of an observation. You want to look at the patient. You want to see how they're standing. You want to observe where the shoulders are. You want to look at the hands itself. So he currently is demonstrating a little bit of what's called too many fingers sign. So if we were to look at him from the back, his hands are a little bit internally rotated. We could see the fingers in the back. So that tells us that maybe the muscles in the front are already a little bit tight, pulling him forward. So we're already observing that. He might have a little bit of an imbalance between the muscles being stronger or more tone in the front versus the muscles in the back. I'm also observing the neck itself. I want to get an idea of where his neck is positioned relative to his shoulders. Is it too forward? Is it too far back? One thing to know is that your shoulder blades predominantly are hanging off the neck itself. And so if these muscles are super tight or tonic, they're actually going to pull on the neck. He might be experiencing some neck pain in addition to the shoulder pain that he came with. So this is kind of what we do right off the bat with a little bit of observation. And of course, you've already done your subjective assessment. So he's already told you if his shoulder hurts because there was some trauma to it, or his shoulder hurts because he tried to throw a ball. Maybe he heard a snap, he heard a pop. So you've already gathered this information, which then helps kind of guide where your assessment is going to go to. So the first thing you want to do is a bit of a range of motion assessment. So I'll get him to bring his arms all the way up, 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 and you just want to see how that shoulder's moving, if he's experiencing any form of pain with that. I obviously want to compare to the other side as well, just to get an idea. So I'm going to do all the ranges. We're going to do his flexion, which is what he's doing here. Typically, when somebody does the flexion, I like them to have the thumbs up. That helps clear things a little bit more on the shoulder. You get a better sense of what his full flexion is. So I'm going to come back down. We're going to work a little bit on the abduction as well, bringing the arm up, going all the way. Again, we're just trying to see how that shoulder moves. If you can do both sides together. We're trying to see, does one side move more than the other? Does he feel more comfortable with one side? Is his neck leaning more towards one side? These are important things. Another really important thing to note is the distance. So is one distance between the neck and the shoulder larger than the other? This typically happens if the shoulder blade has a hard time upwardly rotating on one side versus the other, or if he has any improper scapulohumeral rhythms that's causing these types of things. So we're really observing this. Another really good assessment you can do to get a good idea of what the range of motion is, we can get the client to just go straight against the wall like so. From here, he's going to have his hands just like so, flat against the wall. Try to stay as close as he can to the wall. We're going to get him to bring his arm all the way up and around. And we want to see, can he do this without doing a lot of thoracic rotation, upper body rotation? As he's doing it, can he clear it? Is he getting stuck at any sort of range? This again gives us a better idea of his overall shoulder health. So now to go a little bit more specifically, you've done your range of motion, you've realized generally his range of motion is okay, or you might have not. So now you want to do further tests to test for specific things. So the first thing that I do is I do what's called the general impingement test. I want to get an idea, is he getting jammed up? Are his rotator cuff muscles, specifically the supraspinatus, is it getting jammed up? So what I'll do is I'll get him to fully internally rotate, just like so. I'm jamming everything up in the front, and then I get him to go up. Now, most people who have impingement syndrome will experience pain around this region. Now, there are some clients that might have impingement syndrome, but you might not necessarily, they might not tell you they're having pain here. So you get them to go up all the way, and I'm starting to feel like he's got a little bit of restriction there. Even at this point, they still might not tell you anything. So make sure at the end you always give a bit of overpressure. That overpressure, if they still don't have pain with that, then you know they're in the clear. It's most likely not an impingement syndrome. But if you do give them that overpressure and they're like, ooh, that really pinches things, or that makes things worse, then you know that could be a form of impingement syndrome. So I'll do that just to kind of clear those things out. Then I'm going to go into a little bit more of just general strength testing. I might get him to bring his arms straight up, palms up. I'll get him to resist me here. So don't let me push down. Resist, resist, resist. He's doing okay. No pain with any of that. This is also another test to check the integrity of some of the muscles around here, long head of the biceps, sometimes some of the rotator cuffs. And in here, if this was a positive test, I would apply pressure. I would tell him, don't let me pull your arms down. I would apply pressure, so resist me, and note, and if he has an issue with it, on the one side, it'll slip. He'll essentially resist, resist, and then one side will go down. That tells us that there's something going on with that tissue, okay? The other test that I'll do after this is, again, we're going to continue our strengthening test. So I'll bring his arms up. Now I want to test his abduction. So I'll bring his arms over here. I'll say, resist me while I'm pushing you down. Resist, 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 resist. He did okay. I'll even get him to bring his arms down by his side. I'll get him to resist the biceps flexion. Resist, resist, resist. He's doing okay. Biceps seem okay. I might get him to resist some external rotation. I'll get him to resist internal rotation. And again, those things all seem okay. I might want to even take it to another step. You know, let's say he's an athlete. He's good with his movements and mobility, and maybe some of those things aren't clearing out. I'll get him to bring his arms up. I'll get him to actually go into the end ranges, right? And now I'll get him to resist here. Don't let me push you back. Okay, so now I'm trying to resist his mobility in a weakened position. I'll push that way. I'll push this way. I'll get him to resist. Again, I'm trying to check the overall strength of those muscles. Once I've done that, now I'm going to go back to doing some more of those specific special tests. So the first one we already did, which was the speeds test. I might want to do what's called the empty can test next. This again checks the integrity of the supraspinatus. I'll start off, I usually like to do it in various ranges. I'll start with the hands straight, thumbs down like so. His elbows are straight. I'll get him to resist me, resist, resist, resist. In this case, he's doing okay. My next step would be, okay, now let's get a little bit more of a bend in those elbows, create a bit more torque at the shoulders, and now I'll do it again, and I'll see if that hurts him there. If this test was positive, and he's like this, and I'm resisting, you'll notice all of a sudden one side will drop, or he won't be able to control it as much. Typically, this one doesn't take much resistance before the patient says, that one hurt me. And then you kind of get an idea, okay, some rotator cuff stuff going on with this particular test. The other things that I kind of want to do is observe if, again, he does have that rotator cuff injury or calcification. Now, one of the key differences in somebody who has calcification versus just a general rotator cuff injury. With calcification, typically the client will say, I just woke up one day, I couldn't even move my shoulder. It was tremendously painful. I could barely move it. In fact, some people will go straight to the hospital because it just hurts so much. They can barely have any movement in that arm. Now, the really interesting thing with calcification, after about 3 to 4 days, you'll notice the pain will significantly come down. It'll still hurt a lot, but they'll notice that at least they'll get some form of a range of motion back. They'll still be able to move it. They'll move it very gingerly. They'll start kind of moving their arm kind of like this. They still have some sort of control. They can control it. It just hurts them a little bit. With rotator cuff tears, what you'll notice is the person will say, yeah, I'm okay here, I'm okay, and then bang, it just gives way. So they'll come up, up, and then bang, they just can't control it anymore. The muscle's literally giving way and it's falling down. So that's what you're looking for these ones. If you're trying to see if it's a painful arc or if it's a arm drop where it's coming down and the arm is dropping, those are the things that I'm looking for in here. The other test that I might want to do is I'll get him to face that way. This is a wonderful rotator cuff test as well. I'll get him to bring his arms behind his back, just like so, and I'll get him to bring his palm closer to mine. So he's going to push out, coming towards me, and I want to see how well can he control that. So come towards me, come, and I'm trying to see, does he have good control? Is the arm giving way? Is he able to maintain and sustain that mobility? Does he have to really crunch forward to be able to do that? What's his shoulder blade doing here? Is it popping out? Is it popping in? These are really important things to do. And so that's kind of generally what I'm looking at when I try to do a real quick screen of the shoulder. Again, just as a quick bit of a summary, I'll start with a bit of observation. I'll see what's going on. I'll do a bit of range of motion testing. I'll do some general strength testing. Then I do my specific tests for rotator cuff tears, specific muscles, so on and so forth. Of course, there's a whole other set of tests that I would do if he's going to be lying on a bed. But just in general, this is something really good to observe. And again, another really key thing to remember is that rotator cuff tear versus calcification. Calcification, right away, tremendous amount of pain. Usually lasts about 4 days. After 4 days, they'll all of a sudden start to regain some mobility back. With a rotator cuff tear, they could still have that pain, but it lasts a little bit longer, and you'll notice that the muscle literally will give way. Whereas in calcification, they'll still at least be able to somewhat control it within the range that they're comfortable in. One more thing is that don't panic with shoulder injuries. There are a lot of times patients will come, especially if they've recently hurt their shoulder, they'll come in and present with a tremendous amount of pain in the shoulder. And if you're not used to it, you might think, oh my God, this is the worst thing I've ever seen. You need to go to the hospital right away. But actually, shoulder, because it's such a small joint, and there's just so many things going on here, even a little bit of swelling in the area can completely shut the joint down. And so if you just give it enough time, you'll be surprised. Within a week to 2 weeks, all of a sudden your patient might have tremendous amount of range back, more function, more mobility. They might not be 100%, of course. That's why they need your help as a therapist. But nonetheless, they'll be in a much better path than they were when they initially presents themselves. So early on, make sure you're giving them some good range of motion exercises and things like that, just to kind of build their confidence in that mobility and go from there. And maybe one more thing we'll touch on in this video just really quickly is frozen shoulder. So with frozen shoulder, just remember that one takes even longer. So they'll present as if I was explaining the whole calcification thing, where they just can't move it at all initially, but it just lasts longer. Even 2 weeks, 3 weeks after that, they're still having a really hard time moving that shoulder. And with frozen shoulder, just remember, it can take up to 2 years before the full function returns and the person gets better. It's not a quick fix. This is where education becomes really, really important. And in frozen shoulder is far more common in females than it is in males. And part of the reason is a lot of newer studies have recently discovered that estrogen is a very protective hormone against inflammation. And in females, post-menopause, once estrogen levels start to drop, they lose that protection against that inflammation in the shoulder. And the shoulder, for some odd reason, all of the structures, that capsule, all those ligaments around that joint, they're extremely sensitive to inflammation. And even a little bit of inflammation in that area can completely shut that joint down, create adhesions, and it gets that capsule to fully tighten up like a glove around that joint. And as a result, the patient will just find that they can't quite move it. And what you'll notice a lot of times is you'll notice a lot of shoulder coming up like this, and they just can't move it, right? And this, again, is one of the biggest differences between all the other conditions. With calcification, rotator cuff, stuff like that, you don't often get this right away as you would if you see it in a frozen shoulder. So there you have it. You found that helpful?
100%.
Perfect. Thank you so much for watching. Other videos that we're going to be talking a little bit more about, we're going to be talking a bit more deeper about those specific conditions, how we treat it, how we go from there. If there's anything specific you'd like us to talk about or discuss, please comment below. Until next time, thank you, thank you.